Welcome to the first day of the rest of your life. My name is Andy Zaremba, and today I'm going to extend an open invitation to anyone that wishes to do battle on chess.com.
Whoa.
If anybody wants to
Chess
meet
players
me on the proverbial metaphorical battlefield, which is the chessboard, find me on chess.com. Just Andy Zaremba. Just search me. You'll find me. We can do battle. We can combat with our minds, and it's a lot of fun. So if you want to reach out, I just thought they're out there today. I'm playing a lot of chess these days.
Are you sponsored
online.
by chess.com?
I'm not. I should be, though.
You're just a fan.
I'm a big fan.
Cool.
So if you want to play some chess, come by and look for Andy Zaremba on chess.com. That's not normally how we open the podcast, but I thought, hey, do something different today, And also, if you'd like to learn more about me as well, you can visit andyzaremba.com. And again, that's the andyzaremba.com is a coaching and consulting page. So I'm not going to go into too much detail around that, but essentially what it is a hub for all of my entities. I have various projects going on, Vancouver Real, Mindful Mass, Float House, Man Talks, all these different things. And I decided to amalgamate them all under one spot. So if anyone wants to know what I'm about and sort of what my ideas are, then you can visit andyzaremba.com and check all those things out. So, and also, we have another co-host today. I should maybe mention you as well.
Oh, okay.
My brother Mike.
Hey, everybody. How's it going? Nice to be here with you. Thanks for joining us, and I'm looking forward to today's show. But first, before we get to our guest today, we are podcasting here out of Float House at 70 West Cordova Street. Floathouse.ca is our website, and they are the primary sponsor of the Vancouver Real podcast. And if you haven't heard of flotation therapy, it is a great holistic alternative modality for a lot of kind of modern contemporary ailments of burnout, fatigue, syndrome, anxiety, which seems to be really popular these days. Everyone just can't get enough anxiety, so you can come and treat that here. And other mental health issues as well as chronic pain issues. So if you haven't explored flotation therapy for these applications, which are quite often non-contraindicating with anything else, definitely check out the info at floathouse.ca. If you want to use the promo code VancouverReal, you can save 20% on a single float.
That's wonderful, Mike. I haven't floated since last week, and I definitely need to get back in there.
I've got like the once a week train going on right now.
That's good.
Thursdays at 3 p.m. are my spots.
I've been on the train for a while, except the last couple of weeks I fell off. I need to get back on. The once a week train is definitely ideal for that.
Yeah.
For maintenance of the mind and the body.
That's right.
Also, give a shout out to the Vancouver Real community. I know we haven't had an event in a while, but we've been kind of busy. Actually, we kind of did. We had the Carlos De Leon event, which was
we
really
did the
great.
collaboration.
And for those of you that were there, thanks for coming out and supporting. Yes. That was really cool. We have the audio. I think we did get emailed the audio, which we could probably just release as another podcast if we wanted to.
I'll ask them, make sure that they're cool with that. I think that'd be really cool.
Yeah,
Why not?
Why not? So that's happening.
Shamanism.
So Vancouver Real community. Mindful Mass, check out Mindful Mass Vancouver Meditation Flash Mob on Facebook or mindfulmass.org. We're going to be having a giant mass meditation on June 21st at City Hall for International Yoga Day. And we haven't figured out the whole logistics of the day yet, but it'll probably be around 6:30, 7 p.m. And we will make the event for that shortly. Also, Man Talks. We have an event scheduled on June 11th. Event still pending, but it'll be released within a week or two as well. And that will be with Carlos De Leon. And we are going to be diving into the masculine shadow or the subconscious. And he's going to explore that. And there's going to be some experiential components to it as well. So we can all explore some of the shadow sides of ourselves and then ask a lot of questions afterwards. That's a 2-hour event. And you can find that on mantalks.com or at the Man Talks group page.
That sounds awesome.
Open to men and women, by the way.
I'm going to be there. That's fantastic.
Yeah,
June what?
June 11th.
Awesome.
And, of course, on some Monday for Man Talks Monday. And I think that's everything.
Yeah, let's move
Except
on.
for Brain Evolve.
Brain Evolve, Grind Bar.
Yeah, the two things. Just
Google it.
Photos, pick them up. Now, today, I started thinking about chess. That's why I threw out my chess handle to the internet to do battle with all my fellow Vancouverites, because I was thinking about a blunder. And I wasn't going to talk about the blunder, but I made a blunder for this podcast. And our guest today is somebody who I met at TEDx Stanley Park, funny enough. And hopefully you will be a future speaker there next year. And I blundered because I thought you thought you were coming in to meet the producer of TEDx Stanley Park today. I thought you were coming in because we were going to do an interview on Vancouver Real. But the good thing is it all works out because you have a great subject to talk about, and we have a podcast for you to talk about it on. And, of course, the whole Roger Killen introduction is going to happen and all that, so that's all good. But I want to explain my blunder, and, without further ado,
Introduce
Dr. Mo.
Dr. Mo.
Welcome to Vancouver Real.
Thank you. It's very interesting that on your side, you are introduced yourself as somebody who is interested in chess, and you play a lot of chess games lately. I've never played the chess back home, and I just waited till I retire from most of my duties, and I started learning chess.
Oh.
You know what? It is really
I started
addictive.
learning chess, and it seems it is a very addictive game.
Yeah.
It is a very good game. It keeps your brain going, alive.
It's amazing, right? It's so complicated.
It is. Yes. Yeah.
I mean, you don't think it's that complicated. Like, you know the moves, you know the rules, but then it's like,
Right.
no, when you start thinking about chess, it's a rabbit hole.
So it might be an excellent trade-off that we can play chess, and I can help you with whatever information that you require in your podcast.
Or maybe you can just like psychoanalyze me and figure out what's wrong with me.
Well, you're a great man. There is nothing wrong with you.
Oh.
Okay, you're down to earth.
Thank
You're very pleasant. There is no doubt of that. And you do not belong to the Rate Society. You belong to humanity.
Yeah,
Indeed.
that's very true. So the reason I brought that up, and you can maybe help me with psychoanalyst, or at least answer some of our questions on the podcast
Right,
today,
yeah.
and related to such a subject, is because you are a psychiatrist. You are a clinical associate professor at UBC, and you're also a psychiatrist at Lionsgate Hospital. And we were talking a little bit about what you might potentially be speaking about. And it's a very interesting subject, which I just heard about for the first time today. And it actually prompted the conversation of what we could actually call this podcast, and maybe even the name of your talk. Who knows? But the name of the podcast is going to be Medicated to Death. And you were explaining something to us, which I'm going to let you explain because you do it much better than I ever could. And it's something that is essentially a man-made disorder that we can cause to people because of over-medication. Is that correct?
Yeah, that is true. It is very unfortunate that we create what we call iatrogenic disorder or iatrogenic syndrome, something that is created by medical practice. It can be either created by physicians, nurses, chiropractors, physiotherapists, anyone in the area. And what does this really mean? It basically either the effect of medication on the body or the effect of any procedure on the body. And as far as physicians are concerned, the most common is the effect of medications on the body. And that takes us to another area of polypharmacy, administering more than one drug, or the effect of multiple drugs on the body. And this is called a drug-to-drug interaction. That we see this mainly in the older age, because in the older age, the physiology is different from the young age. So even the drug-to-drug interaction on the older age is different from people your age.
Right.
Okay? So what we know that people are living longer. What we know from the World Health Organization that by the year 2050, we're going to have more than 15% of the population, they are above age 65.
Mm-hmm.
What we also know that those who are above 60 years of age by the year 2050, we're going to have 2 billion people in this category. We're dealing with huge percentage of population that they are going to be affected by the polypharmacy, and 11% of them we will create iatrogenic disorder, something that does not exist, we create.
Right, and that will have huge consequences, not only on their health, but financially as well, huge financial strain.
Okay, so basically, that's a very good point. Economically, you are feeding an industry of what you called it, medicate to death. That does not make sense.
Right. Now, you were sort of describing the case in which you discovered this for yourself. Would you mind telling a little bit about that story and how you came across this?
Well, it happened a few years ago that I received a telephone call from a colleague of mine, a family physician, that they are having this difficulty to treat the 90-year-old lady. Her family refuses to put her in a nursing home. She has been suffering for 5 years since the death of her husband. She was seen by many specialists, and everyone entertained a diagnosis. As I mentioned it to you before the podcast, there is a vicious circle that is called symptoms. You have symptoms, you go to see the doctor, then you get a diagnosis, you have a diagnosis, then you have a medication. And unfortunately, this lady was a victim of this vicious circle.
And so basically, the medications will produce symptoms. The side effects. Those side effects get
Which are
re-diagnosed.
symptoms, right?
They get re-diagnosed, and then they get re-prescribed another medication to deal with the side effects. And then again, those new medications produce a new side effect, which then get
It's
re-diagnosed
diagnosed
and then remedicated. And you're describing this spiral of medication.
That is correct. So what happened is I received her file, and then I put things together, the time factor of each medication in relation to the diagnosis and in relation to the side effects. And then I discovered that the poor lady has been suffering all those years for really nothing. So it took me about 2 months to stop all the medications, because again, in the old age, you cannot stop medications suddenly. You can have more crises and more difficulties with this lady. So this lady was diagnosed with high blood pressure, diagnosed with Alzheimer type of dementia, ischemic heart disease, anemia, GERD. GERD is gastroesophageal reflux disorder.
Right.
Okay. And was diagnosed with congestive heart failure, interstitial pneumonia, pulmonary fibrosis. The last one was given to her was Parkinson's disease. So I started to look into the how did the circle start and when. She was given a medication called Aricept for Alzheimer. Okay, and that medication started to give her side effects in relation to her stomach. Then she was treated for gastrointestinal disorder, which we called it the GERD disorder. And that Pantaloc, which was given for her, it caused side effects. And those side effects affected her ability to sleep, side effects in relation to her. She became nauseated, vomiting, and unfortunately, it didn't stop there. The medication continued. She started to take antidiuretic. Okay? And then Seroquel, antipsychotic. And then we have a diagnosis of heart disease. Another medication. Medication of interstitial pneumonia. Another medication. Antibiotics. It affected her kidneys. And then the last medication, it was levocarb, which is medication given for people with Parkinson's disease. Okay, and that was in relation to the medication that was given for her gastrointestinal disorder. Then she started to have symptoms of Parkinson's. The medication was given levocarb, and the levocarb affected other organs. She went into that complicated, compounded, vicious circles.
So can you describe when you saw her, when she was at the peak of all these medications?
She was agitated, she was nauseated, vomiting, going to the toilet every 5 seconds.
Really?
Couldn't sleep.
How old was she roughly?
She was 90 years of age.
Oh, quite old. Okay.
Yes.
Wow.
Okay, and no medications helped this woman. She started to hallucinate. She was delusional, and she thought everybody is coming to attack her, and
paranoid.
Paranoid. 2 months after all of this had stopped, all these medications, she lived a wonderful 4 years. Her house was open again to receive her family, her visitors. She was sleeping well. There was no agitation, no paranoia.
Wow.
She started to laugh. But of course, for her age and for the original diagnosis of Alzheimer, she actually started asking me out. She wanted to marry me.
Wow, good for her. What a recovery right there.
Yeah.
Okay, she was a great success.
Right.
Wow. Yeah. So it seems like there must be some sort of a problem then, because every medication you take there's sort of a trade-off. We know it's going to help one thing, but then there's going to be side effects. So you're saying that hopefully the thing it's helping is going to be better than the side effects that it has. But it was compounding.
Yeah.
Now, my question would be that if they know that those drugs have certain side effects, how come they missed that side effect instead of and they diagnosed it as another disease or illness instead of saying, oh, that's the side effect of the drug? How did they miss that?
I don't know if they had missed that or they undermine the drug-to-drug interaction on the body, especially for the old age.
Okay.
I think this is the case here.
See, this could be really useful information, especially when dealing with maybe someone's parents who are getting older, or if you currently have a family member in the healthcare system. This is something to be very aware of.
Well, to your surprise, after we washed out all her medications, there was no heart disease, and she was seen by the same cardiologist.
Wow.
Okay? No heart disease.
Jeez.
She was seen by the same respirologist. No respiratory fibrosis, no lung fibrosis, no interstitial pneumonia, nothing. Okay? She was seen by the same gastroenterologist. No no GERD disease, and so on.
Hmm.
She was not Parkinson's. This is a clear indication that what we have created is a spider web of disorders.
Hmm.
And the only way was to wash out all these medications. And we succeeded.
Amazing. So if somebody had someone who is being highly medicated right now for various disorders, and they suspect that perhaps this is something that's going on, it could be the case for them, how would they start even to approach their healthcare practitioners to assess for this sort of thing?
You have a very, very good question. When I was running the Department of Psychiatry at the Lionsgate Hospital, I would encourage the patients to be admitted to the hospital. We review the diagnosis. We give them the choice to clean them up from all these multiple medications, and we start afresh with them. Unfortunately, we find this problem mainly with, as I said, old age or mental patients, especially those with chronic disease. It is very sad that we have created a big number of this population that are living between us, and they are taking multiple medications, and
the symptoms are caused by the medication.
It keeps going.
Yeah.
So I question all medical students and young physicians. I tell them bluntly, if this person is taking all this number of medications, they come to you to emergency, you admit them to the hospital, and you give them more medication, that does not make sense.
Right.
It really does not make any sense. Maybe they are coming here to tell you, take away some of the medications you are giving me.
But they're just piling them on.
And they are piling them. Yes.
Right. So earlier as well, you had mentioned that this could be because they don't have the time. So it's maybe I'm going to assume that it might be easier to prescribe a medication and then move on to the next patient. Could that have something to do with it?
I agree that most probably the case, that they just either they don't have time or they are not really trained to recognize that this is a reality that we are dealing with.
The reality of the drug-to-drug interactions?
Yes.
Right. So you think that needs to be further educated on in their training and a bigger topic? And I assume that's kind of like why you want to do the TEDx Stanley Park talk next year, is to kind of bring this
to the forefront.
Yeah, to the forefront a little bit more, give a bigger voice to it.
Yeah. I think it's hugely important. I'm curious as to how...
Well,
sorry,
put it this way. We grow older, there are more disabilities.
Yeah.
And there are more chronic health conditions.
Yep.
There are more symptoms. But it doesn't mean the answer is a medication.
Right.
What do you think some of the answers could be other than medicating?
Well, actually, if I am wise, I'll just come to the float house here and distress myself and sleep well. And
well, so you're saying basically good healthcare practices and
lifestyle.
Yes, a
nutrition,
change of lifestyle,
exercise,
right.
fresh air, socialize.
Correct.
Different these things.
We already know that.
These are all medicines as well.
Those are that is true.
Then I'm going to take this to a different level and say, why has the current medical system, if you want to call it that, relied so heavily upon medications for solutions if there are lifestyle solutions available?
That I cannot answer that. Okay. But I think it's a political decision, isn't it?
Well, if you were to speculate, I mean,
Probably there is inadequate knowledge of the impact and the effect of holistic medicine on us.
Right.
Maybe.
Well, it's probably, it could be obviously multifactorial, in the sense that there's maybe political, economic, just the direction of research. Sometimes, like when research kind of goes in a direction, it just keeps going down that direction.
And most of the research is run by drug companies.
Okay, well that's significant.
The fund
right?
for research is coming from big pharma companies.
Right.
right.
Okay.
So
Another point is we have multiple prescribing physicians. That's also a problem.
Right.
Right.
Okay,
So
and
the
then when you go finally to
overprescribing.
see your own family physician, okay, for a symptom or this, he doesn't know or he doesn't have the time to deal with all of
Isn't that the job of the pharmacist, though? To like look at all the medications that you've been prescribed, see what you're currently taking, and then say, oh, you know, these things are going to interact that way, or you shouldn't take them together, or something like that?
The pharmacists are doing a good job, and I believe we in Canada here, we especially in Vancouver, we have a system to recognize most of this, and the pharmacists, they alert the patients for the side effects, and they alerted the patient for possibilities of developing any of those symptoms. But maybe because of the trust in the medical system, in the medication, in the treatment, in the physician, I don't know.
Right. So there's some kind of gap. There's a hole going on right now that isn't being recognized for some reason.
I wouldn't say not recognized. I would say not dealt with in a serious way.
Okay.
Yeah.
So, you know, what comes to mind to me right now is leading cause of death. There's heart disease, cancer, and I believe the other one is medical malpractice or mispractice or something like that.
Mm-hmm.
Is that correct?
Yes.
Yeah. So I guess you could sort of lump in what you're talking about with that third leading cause of death, like, wrong procedure being done or misdiagnosis or wrong medication being administered, those type of things.
Well, what I can tell you for sure that this is what I call it 4x4, okay? The most conditions responsible for the premature mortality. One is a cardiovascular disease, chronic respiratory disease, cancer, and diabetes. Okay? And the 4 lifestyle risks are smoking, harmful alcohol use, lack of physical activity, and the high salt and the high fat diets, leading to the above conditions.
High
So
salt
4x4.
and high fat, eh?
Fat diets. Going back to your question about the doctors who do not recognize the iatrogenic disorder. I remember one time I was doing consultation on the medical floor because my area of expertise is in psychosomatic medicine. This young man, he was diagnosed with bipolar affective disorder, but he's always on the medical floor treatment for phlebitis, okay, which is a result of deep venous thrombosis in both legs, okay? At one time, he was admitted to ICU because he had this in the pulmonary. And the pulmonary embolisms, this is a critical case. It is live or die situation.
Mm-hmm.
This is not a joke. You discover that all those years he has been taking this anti-epileptic medication that we use for the bipolar affective disorder, and that reading psychiatrist, that reading physician never questioned that it can cause deep venous thrombosis and the phlebitis.
Wow.
We stopped the medication, okay? And then the guy has been okay after that.
That sounds... I mean, what do you
I
attribute to that
I could
to?
go
Is
on
it-
and on and on for all
So there's so
this.
many cases that you could probably cite, right?
Yes.
So knowing that, so I guess you don't really know the exact one cause of why this is happening, but what...
I'll tell you.
Okay, you have
in
an
my
idea.
in
Okay.
my opinion,
Yeah.
in my own humble opinion, I know. And this is what I do, because I give basic clinical courses to medical students. The one that I am good at is interview techniques. So even with young doctors, foreign medical graduates, residents, this is what I emphasize on.
Medical
Take proper history. If you cannot take proper history, you are not good. You shouldn't be practicing medicine.
Right.
And in order for you to get a proper interview, proper medical history, you have to learn how to interview the patient. How
That
to
makes-
develop a trust between you
Right.
and the patient.
That makes
You will
complete
work
sense.
together.
Right.
Otherwise, you will be working against each other.
It's a more of a therapeutic alliance
Of course it
by the
is.
medical doctor.
You have
which
to build up the
Right.
therapeutic alliance.
Right.
So again, what comes to mind immediately with that is sort of the time restrictions put on doctor appointments. So it's like the doctor is seeing a patient, they have whatever time allotted for that patient, and then they have to move on to the next one, right?
Yes.
So again, it's like multiple factors probably contributing to why that's happening. But you're saying effective interviewing of the patient and really understanding that patient could be a solution for this.
Excellent.
I wonder if there could ever be
It
like
is actually a solution for a lot of things.
So that, to me...
And
would-
economically, as Mike was talking about,
Right.
economically it is feasible as well.
like I wonder if there's because of this problem, and I'm just literally thinking out loud here. What if there was a specialized position, a new profession created to support the doctor just with the history and the interview, that's all they do. You know what I mean? And they're specialized as to gather the proper information from that client, and then a doctor then I don't know.
Wait, no, I was going to say, what came to mind when you said that is sort of new medical technologies where they're going to have your entire medical history like on your watch or maybe even on a chip in your arm. You go to the doctor's office, they scan it, everything comes up, everything. And the doctor sees it all without the patient being able to even hide anything if they wanted to.
Hopefully with the new practice and the new trend of creating a new layer of nurse practitioners, we might not have the same problem as we have it now.
Right.
They
So
will-
you're thinking sort of like Mike's initial suggestion of
Yes.
having another type of specialist, if you will, to build, maybe even building the relationship with the patient. Maybe that's what it could be,
True.
right? Because if it's a trust issue,
Well, there's trust, there's time, there's that ability to create that human to human connection for the therapeutic alliance. Lots of things, right? And so, yeah, whether that gets further developed in the medical and the doctor, or it gets developed by a nurse, or a new role emerges almost out of that. Who knows, right?
I think also another factor is the College of Physician and Surgeon
Mm-hmm.
should take the job to be serious enough where they can also work with the physicians. Because when you have lawyers from this side and lawyers from that side, it doesn't really make sense. But if you work with each other in a peaceful way, educate them more, we might succeed. Instead of consider the doctors victims, aggressive or wrong until proved otherwise. Okay?
So just to be clear on that. Okay, go ahead. Sorry.
Like, for example, I'll tell you a case. Okay? I was called one time to see this 80 years old lady post-surgery to see why she is confused. And then when I started to do my assessment the way I explained with the history and recommendations, I get a call from the surgeon who operated on her the day before. He's telling me, are you out of your mind? The lady is dying. Okay, why do you order all these medications? All these investigations. Why are you telling us this? I said, well, you asked me to find out why she is delusional, why she's confused. Okay? And in this age, delirium post-surgery is very serious. Unfortunately, I'm talking to the surgeon now, that you missed the point, sir. You shouldn't have operated on her. You knew that she was terminal and she's metastasized her everywhere. Why did you operate on her? You want me to give her medication to kill her? Is this why you're asking me to see her? So, things like that, if it is reported to the college, you will not go anywhere. You have lawyers, you have this, you have that. But
right, so it gets caught up in the...
It gets caught up into all of
legal bureaucracy.
Yeah.
Legal hierarchy, legal hierarchy and all of this. And it does not make sense to me where we use, where they become defensive. Okay? But to start with, you need to sit down with this surgeon, talk to him, educate him, and stop this nonsense from happening. You know what I mean?
Yeah.
So at this point, like the physician gets, threatened or attacked, or they have to defend their actions. Lawyers
and
get
then
involved.
Everything is covered up, and we call it legal names.
Right.
Same like my case that I presented. Okay? If you bring all those physicians and the specialists, they will agree of the heart disease, of the respiratory disease, of the GI disease, of all of this, if it goes to court. But if it doesn't go to court, we will educate all of them the same way as I'm educating you about this case.
Right. Is that kind of because, like, elements of our society, we don't want to leave room for error, right?
We don't want to admit our errors.
Right, okay.
Okay?
That's interesting. So what do you think? Oh, I can plug that back in. What's the main reason for that then?
Maybe our narcissism. Maybe our
insecurities.
So do you think it's sort of, for lack of a better way of saying it, like an ego problem? Like they can't admit when they make a mistake either.
True.
Or is it also not safe to admit to you make a mistake, because then your whole profession's at jeopardy?
You're exposed.
Like, what happens if? Why can't you
made a mistake?
Make
now
a mistake?
Patients don't trust you. Who knows? Maybe you're under some kind of investigation now.
Your ego.
Your whatever. You know what I mean? So there's like lots of reasons as to why these sorts of things are happening, right? Do you think that...
I learned from one of the... Excuse me for interrupting
That's
you.
okay.
I learned from one of my patients who had a motorcycle accident. I learned from him something very, very nice, actually. He said, "Doctor, if you want to be good motorcyclist, you have to understand that accidents is a norm.
Accidents happen.
They happen.
Yeah.
Okay?
Mm-hmm.
Don't deny that."
Yeah.
And unfortunately, that's he's telling me, that was his case, that he denied that he could not have an accident.
Couldn't happen to him, right?
It couldn't happen to him.
Right. It's like the smoker who can admit that they're at risk of lung cancer for smoking. Oh, it happens to everybody else, but not me.
But not me. And I think this should be the new trend for the college, that we all do mistakes.
Mm-hmm. Mm-hmm.
And we have to recognize our mistakes. And we have to know how to deal with them. This would be the solution.
So maybe it's a twofold, like creating the culture where people are allowed to admit when they make a mistake, they're making it okay for them to be wrong, and also working with the physicians to not get so, like you said, defensive maybe when they do make a mistake and they try to hide it or they don't report it properly or whatever it is. So it's creating the environment where they're allowed to admit it, and then maybe not get severely punished, especially if it's an honest mistake, right?
You see, I studied continuous quality control management, and I visited Japan. They are the leaders of quality control. Their system is exactly what we are talking about. Mistakes happen. It's how to fix them.
Yeah.
How to let the system survive and operate with minimum mistakes. They do not point fingers to who made the mistakes.
They just say it was a mistake.
They just want you to understand how did it happen and how do we fix it.
Yeah, how do we evolve?
The interesting thing about that is that sort of mentality is, I would say, definitely becoming more prevalent in, say, business and the corporate world, because when within a company, if somebody knows that they can openly share a mistake, it's actually going to cost the company less money in the long run. They can train other people to prevent that mistake from happening again. So there's all these advantages to having an open dialogue around those kind of things. It seems like the Japanese system has sort of taken that and adopted it to the medical system as well. And perhaps maybe it's because in North America, I'll say, maybe they're just they're stuck in their traditional ways, maybe, and they haven't been able to evolve past that. I don't know. What would you think about that?
It's exactly what I mentioned, that we have to change the way we think. And when we change the way we think, we admit that we do mistakes. We are vulnerable to do mistakes.
Right.
And we have to accept how to recognize them and how to protect our patient as well, not to protect our ego. And we should not be punished for that.
Right.
Yeah.
Because that's what I was thinking too. It's like one thing for business if a mistake happens, granted, there's danger in businesses too. Like people get hurt in factories and warehouses.
Sure.
It could be life or death.
Could be.
Same thing in medical organizations. This is someone's life. This is their well-being. So you can see why, the stakes are high. There's a family that's going to be caring about the results of this, and then you made a mistake on my child.
So maybe just changing the culture where there's
and then when you keep everyone blind because you create new diagnoses and you are protected by lawyers and this and that, it does not make sense.
Yeah,
Really
I think this can be extrapolated beyond business, beyond medical, and into just culture and society at large. I think acknowledging that people do make mistakes, acknowledging that people do change, and how they were in the past doesn't necessarily mean that's how they are now.
Yeah.
Like just being a little bit more open to forgiveness, and that mistakes and accidents happen, and people, can learn from them.
Well, let's just take it a little bit further then.
Yeah.
And say, well, why do we have such a phobia around mistakes and failure? Where does that come from? Why are we all so uptight about making a mistake? I would say that it could be a product of partially the education system. It's like you said, a cultural thing where it's like we've been taught that making mistakes are wrong and bad, therefore we should either not admit it or hide it or something, right? And it's like people do seem to have, again, this fear of failure. We could even just call it that. Where do you think that stems from?
Probably we'll have another session for that.
I was gonna say, that's a big
It's
question.
a whole other conversation.
Yes.
Yeah.
But if you could like theorize, if we have enough time, how are we doing for time?
We're at 46 minutes.
Well, we could maybe do another conversation, but I mean, that's one thing I really wanted to dive into. This subject is very fascinating. It's an amazing topic that you've brought to light, which I've never heard of before, and I'm sure a lot of people haven't heard of before. But you also have a whole psychiatric background, which we'd love to dive into more sometime.
Yeah, I was going to say, I think having you back on, I want to talk about the psychosomatic medicine. That's your main focus anyways. I think that'd be a super fascinating conversation to get into as well.
With pleasure.
Cool.
Anytime.
Okay.
Well, we now have our resident Dr. Mo on Vancouver.
Psychiatrist.
But don't say no to Dr. Mo.
That's right. Don't say no.
Don't say no to Dr. Mo because Dr. No Mo's. Dr. Mo knows.
Dr.
You
No
know
Mo.
what I'm trying to say.
Yeah.
Okay.
Words.
Yeah, words. Anyways, Dr. Mo, if somebody would like to reach out to you if they have a question, or do you have a way are you on Twitter? How can people reach you? Or do you want them to reach you? Not really.
I don't know how to answer this because this is the first experience, really.
Do you have a website?
No.
Do you have a personal practice for psychiatry?
Yeah, but I don't do any of this because I'm not really soliciting for me.
No, I know.
Yeah,
I'm just curious if there's
business,
people,
yes.
that, if you have information or resources, but it seems like, between teaching medical students, your clinical practice, and I'm sure all your career worth of networking and relationships, you got probably a full plate out there, and you want to enjoy life a little bit as well, right?
Thank you.
But
I agree.
Hey, you know what? If we got questions for Dr. Mo, send them to us, and we can maybe ask him on the next show if you have a specific question about what we talked about today.
Great.
That'd be kind of a cool way to vet things for you.
Yes.
Well, thanks so much for sitting down today and sharing that story with us, even though we had a bit of a blunder in communication. But that's okay. We're going to get it all straightened out tomorrow. And we really do enjoy having experts of your caliber with your credentials coming on, because it adds a lot of credibility to the show. So thank you very much for joining us.
Thank you for inviting me.
Yeah.
I wish you guys all the best and the success.
We made the most of it, didn't we?
We sure did.
We
and
did,
I think we'll
yes.
do it again too. So
Sure.
anything else you'd like to add in there before we wrap it up there, Mike?
No, just thanks for joining us, everybody. If you enjoyed this episode or any other episode, any form of support you can give us would be huge, whether it's a rating, a review, a like, or a share on social. Anything.
Come for a float. That supports.
Yeah, come for a float. Come check it out.
Yeah.
You probably have heard it every single episode you've listened to. And if you're still humming and hawing, this is your call to action, folks. And it's time to go into the tank.
There you go. And we got Event Central coming up. We got Mindful Mass June 21st. We have Man Talks June 11th. Any other events? No, those are probably the only two right on the radar. But
that's it. That's all that's confirmed. But
AndyZaremba.com. That's an event in itself right there.
Yeah,
Or search me out on
get yourself some popcorn.
chess.com.
I can see you get a nice thing of popcorn and a soda pop.
And watch the show on Instagram stories.
And just go to AndyZaremba.com. Check it out for half an hour.
Well, it's a good hub. I mean, it'll link to all those different things that we have going on anyways.
There
so if you want to know what we do or what I do, check that out. And
awesome.
yeah.
All right, everybody. Thanks for joining us. And until next time.
To whatever is.